Uh, so I'm joined here by Avi, as usual, and Mary and Tom. Mary and Tom are two doctors. Mary is an infectious disease fellow at a major academic medical center in the southern United States, and Tom is also a physician, a hospitalist at a major medical center on the East Coast, and he is a faculty member there. We are using the names Mary and Tom as pseudonyms in order to protect any potentially sensitive information. Certainly, HIPAA is not going to be violated during this discussion, but because of the sensitivity around the information on COVID-19 and the rapidly progressing policies at different hospitals about sharing any information about what is occurring at these different hospitals, we thought it would be better to take an abundance of caution approach and protect the identities of these two physicians as well as the hospitals at which they're attending. So actually, I think none of the four of us are going to be discussing which institutions we're at. And we're just going to be sharing our experiences about what we're seeing on the ground and what we've read, what we understand from academic papers, and what we understand from our training about what is happening with this disease. As usual, you want to follow the official guidelines. If we say something that might seem to conflict with any of the official guidelines, you should definitely follow the guidelines over what we say. And we hope that the information that you will receive here will be useful to you, but of course strictly for educational purposes and not for the basis of any medical recommendation or medical advice. And with that said, I would like to hand it over to Mary and Tom to see if they might have anything to add to this introduction.
Thanks, Kevin. So this is Mary. I'm really excited to be here with you guys. And I do have a little bit of a cough, but I've had this cough for several months now, so I don't think it has anything to do with COVID. So just wanted to put that out there. If you do hear me coughing throughout, I apologize. But excited to be here, and hopefully we can give you guys some helpful information from the front lines.
Yep, this is Tom, agree, and also happy to be here. Glad to help in any way.
This is Avi. Thank you so much, Mary and Tom, for being here. For the two of you, there are currently over 300,000 cases worldwide, with over 14,000 deaths worldwide, and in the United States, where seem to just be continuing skyrocketing with over 32,000 cases, and we're still in exponential growth. Clearly, we haven't tapered off at all. What the public wants to know, there are a number of things the public wants to know. One of the things they want to know is what precautions should they be taking? Is there anything aside from standard precautions, washing your hands, avoiding travel, avoiding unnecessary congregation? One of the things that come up are masks. We may have a shortage of personal protective equipment. Do you think that that's the reason the public should not be wearing masks, or do you think that it would have some protection in addition to standard precautions? And what else can you say in terms of standard precautions that you would advise the public at this time?
So I can start. I do want to emphasize that, obviously right now there's a lot that we still don't understand about this virus and how it's transmitted. We don't know with 100% certainty how exactly this virus transmits from person to person. But we do have some experience with a very close genetic cousin to SARS-CoV-2, which is now the original SARS, which has been renamed, I guess, SARS-CoV-1. And we know from our experience with SARS, 2 decades ago, and also with our experience with other respiratory viruses, especially influenza, that these viruses typically transmit from person to person through either close contact or through by, these little particles sitting on top of respiratory droplets. And these droplets aren't thought to really travel that far. They probably, travel from the person who's coughing or sneezing up to 3 to 6 feet from them. And they don't really hang around in the air for a long period of time. So you essentially cough out these large droplets and then they float and then they drop to the whatever surface that they touch. So that's the rationale right now, that I think is driving the recommendations coming out of WHO and also CDC and other major governments, is that the number one, there's several things you can do to protect yourself, and I'm sure you've all heard of that, all of these things that you can do. But the number one thing that you can do to directly protect yourself, especially in the US where there's high levels of community transmission, is to do this thing called social distancing or physical distancing. And that's to limit the amount of time that you spend around other people. Um, like don't go to the grocery store unless if you have to, stop going out in the public unless if you really absolutely need to. And if you could work from home, then that would be ideal. And that's probably one of the most important things that we can do right now as a society to mitigate further community spread and also to protect yourselves, your family members, your friends. In addition to like just straight up physical distancing, of course, you want to practice good hand hygiene, which I was really surprised by how this became such a big deal. Like I thought people were washing their hands, routinely, and that hand hygiene was just a part of life. But apparently, not everyone washes their hands as much as we think. So hand hygiene is critical, and you probably heard it's not just a matter of running running your hands under water for a few seconds. You really have to use soap. You really have to use ideally a little bit of warm water, and you want to scrub hard for up to 20 seconds. And if you don't have water, you can use an alternative, alcohol-based hand sanitizer. But really, soap and warm water, that is the best way to clean your hands if you do it correctly. And then, all the other things, like if you're sick, I absolutely do think if you're sick, you're coughing, that's the situation that you, as someone in the general public, should hopefully have access to a mask and should be wearing a mask when you're around other people. That is the scenario that I think the general public would benefit from wearing a mask. And it's not so much protecting yourself when you're sick, but it's to protect the people around you from getting whatever you may have. That is, and then this question of should the general public wear these surgical masks in general to protect themselves as they go out in the public? I think there's a lot of controversy on a global scale. In the US, the thought is that the most beneficial thing that you can do is really physical distancing, hand washing, not, going out when you're sick and wearing a mask when you are sick. And there's really not a whole lot of evidence supporting the use of surgical masks broadly, in the community. But if you go to countries like in China or in Singapore and other Asian countries that do have experience with the original SARS outbreak back in 2002, 2003, you'll find that wearing masks in public is actually considered to be like socially polite and socially acceptable. But the idea behind that is that, when you're sick with these respiratory infections, you can be contagious way before you ever develop any sort of symptoms. So it's mostly precautionary and mostly to protect other people from getting sick. But in the US, we don't really have that same, I guess, background or same like societal buy-in. And I think at this point, when there's such a rampant shortage of personal protective equipment, even things as basic as gloves and surgical masks, we're not even talking about N95 respirators. We're talking about just basic surgical masks. We have a tremendous shortage. And I think that we need to triage where these resources go. And these resources really need to go to the people who cannot physically distance themselves, like healthcare workers. or first responders and so on. So that's my take on the role of masks in this world that we currently live in.
Thank you for that. Tom, do you have anything to add to that?
Yeah, to that, I would say that, first, I 100% agree with what Mary's saying about, the shortage of supplies. And so therefore wearing masks in public, probably not the best use of personal protective equipment. Probably best served to have that in the hospitals where there are critical shortages coming up all across the nation. If we had an unlimited supply of masks in the world, would it benefit if we all wore masks in the public? Probably to a small degree. Unfortunately, it's, you're not going to be able to prove that, but it's also really just kind of a resource limited situation. That being said, like the other thing about it is realize that if you are wearing a mask in public for your own protection, a lot of factors have to kind of line up in a very, very prevent you from getting infected in public. Because again, as Mary said, it's the main purpose of a mask is to prevent spread from yourself. So for example, if you're in public and you're wearing a mask, someone would have to be within 6 feet of you, coughing at your face, with a droplet actually coming out toward your mask in order for that to actually be effective, which, can happen. But again, it's not like probably the best use of our equipment.
Thank you. We mentioned a little bit about healthcare workers and their personal protective equipment. Aside from personal protective equipment, are we setting any standards? Have you noticed any standards set for healthcare workers who have specific conditions, such as pregnant healthcare workers, elderly healthcare workers with comorbid conditions, healthcare workers on immunosuppressive therapies, and their potential for providing care for patients with SARS-CoV-2? Are any institutions, or are you aware of any recommendations for them to opt out of care? And if you could just speak a little bit about that.
Yeah, so I can comment on that. At our institution specifically, we are discussing how to best approach that. The idea being that there are going to be certain doctors and certain nurses who are at higher risk for getting severely ill than others. And so we're trying to come up with the best sort of protocols to deal with this. Obviously, you're dealing with a finite sort of labor pool. And so if you take people away, you have to make sure that you have sufficient people to kind of take their place that are healthy enough to take that role. But my opinion on this is that I absolutely do think it is something that we should address, and that needs to be addressed, and that we should try to protect our healthcare workers who are at high risk of getting severe illness if and when they are exposed. How we do that, I think, is going to vary from site to site. It's also going to vary based on hospital size, and also going to be variable based on how much staff and the type of staff that you have available. But absolutely, I think it's important to address.
Yeah, and I'll add that at our institution, we don't have any formal policies coming out of HR at any of the hospitals that I work at, but certain departments are already, they're essentially making a list of staff who are high risk or pregnant or so on. And right now, I think what they're looking for is they're looking for volunteers to kind of step up, and maybe trade out positions with some of the higher risk employees. And I do think there's just so much that we don't know in terms of how COVID impacts especially pregnant women. And not so much, we know that like when pregnant women get the flu, they have a higher risk for severe morbidity and mortality, and it's just a more serious infection that you see in pregnant women, even in ones who are otherwise completely healthy. And it's because pregnancy itself is thought to be an immunosuppressing condition with all the hormonal changes that impact our immune system. So I think it would be totally reasonable, and we should push for this to protect our pregnant workforce. And there are still lots of other non-COVID related roles that these individuals can be shifted to. Like they can, maybe be more focused on televisits through clinic or helping answer pages and so on. I don't see a need for us to put high risk employees on the front lines when we really have no idea what, especially outcomes in people like who are currently pregnant. I don't think it's worth that risk when there's, a need for these employees elsewhere taking care of lower risk patients. So I would be more than happy to cover a coworker who's pregnant, or a coworker who has leukemia, or a coworker who has, who's 80 years old, 90 years old, and high risk for poor outcomes. I would be more than happy to step in and cover for these individuals. But I think right now there's, like what Tom was saying, there's no official CDC guidance on this. There's no official, governmental guidance, but institutions are definitely looking at it, and individuals within institutions are starting to step up. And I think that's the right thing to do.
Yeah. What I am starting to see is, and I think several institutions across the nation are doing this, they're starting to cohort all of their COVID patients together in a single unit, as well as the patients that come in that are still under investigation. That is the people that come in with a fever and cough and are getting tested for COVID, but are not confirmed or ruled out yet. But I think the idea being that you want to keep all these patients in a single unit so that you don't have to expose multiple staff if they're spread out across several different units. So that way you can have just a cluster of staff that are dedicated to a COVID unit, and then rotate them out and then have another group come in. And I think that's probably one of the best approaches that I'm seeing so far. Again, it's all stuff that's not necessarily under a national sort of guidance, because there is not a cohesive sort of national voice kind of coming out about this. But state to state and institution to institution, I think we're starting to see a lot of that. And I think that is the right approach.
Yeah, there's I think in my institution, actually in my institution, I'm in work and research, and the IRB has actually just shut down all of the patient visits. So we're trying to do things remotely as well, and the IRBs at other organizations haven't. Well, some have, but in other states, they may be sure to follow New York, which currently is being hit pretty bad right now. We talked a little bit about the risk factors. If you guys can go just over a little bit of the risk factors, and if any risk factors that people may overlook. I think we know the major ones: hypertension, diabetes, CVD, the immunosuppressed. Is there any high risk populations that people wouldn't have thought about initially, or may overlook?
So Tom and I were talking about this earlier, and definitely the risk factors that you just mentioned are ones that we are all very well aware of. But one that I don't think we really talk about and really does concern us, especially as this virus moves throughout the US, is obesity. We know that we have a major obesity epidemic in the United States and throughout certain countries in the world, but certainly domestically. And, we know that patients who get influenza who are obese may have worse outcomes, have higher risk of mortality, and so on. And probably we'll start seeing that as well here for COVID. And outside of obesity being a risk factor for mortality directly related to COVID itself, but it also, makes it more challenging with a lot of the care that like life support care that we provide in the hospital. So, mechanical ventilation becomes more challenging. And sometimes patients who have obesity have a more difficult time weaning off of ventilators. Even as they do recover, they might have a more difficult time coming off of breathing machines. And then certainly some of the things that I worry about in infectious disease is understanding the optimal dosing of medications, which can vary based on your body composition, based on your weight, based on your, organ function and clearance. So I don't think we've I don't think we've been talking about obesity as a risk factor probably as much as we should, because there are, in a lot of I'm sure a lot of people throughout the country who don't have necessarily diabetes or coronary disease or hypertension yet, but maybe are not at a healthy weight, and that could potentially increase the risk for having severe disease from COVID. I don't know if Tom had anything else to add.
Yeah, I completely agree with the obesity piece. And I think to that, I would add not necessarily a risk factor, but I think, one thing that we are starting to look at a lot more is the risk of co-infection or superimposed infections. So, for example, if you have the flu, I do think, your risk of getting a possible co-infection or superimposed infection later on with COVID, I think stands to reason that it probably elevates that risk. There are studies kind of ongoing taking a look at the potential for co-infections. And I think it's not clearly known yet, but I absolutely think, people who do have active infections with something that's not COVID should also be careful. To this whole kind of discussion about risk factors, I would also add that, when we talk about risk factors, what we're actually talking about is risk for mortality or risk for severe critical illness. These are the risk factors that put people like give people a higher chance of becoming critically ill or a higher chance for dying. But as far as risk for contracting the disease, everybody is at risk.
Right. Thank you. And so when we spoke about the overlooked risk factors, what about clinical presentations itself? I mean, we've all heard of the fever, the cough, the sore throat, and then the shortness of breath. Is there anything specific that seems to stand out as well in your experience? And the other thing people want to know is, do cold symptoms lower the clinical suspicion? So if I have a runny nose, I'm sneezing, I'm congested, does that lower the clinical suspicion for a COVID infection?
No.
Okay.
No.
So that one is pretty easy. It's no. If you have symptoms of a cold, it does not lower the suspicion for COVID-19. But I think, the clinical presentation is.
Sorry, you're breaking up, Tom.
Can you hear me better?
We can hear like 10%.
Any improvement?
Just start talking, I guess.
So I guess I'll just start from the start. The clinical presentation, for the majority of cases that I think we're seeing ground level is it's still pretty much fever and new signs of respiratory distress or lower respiratory illness, which include cough and difficulty breathing. But obviously the clinical presentation is also widely variable. Obviously some people are asymptomatic, some people have very mild symptoms, and then some people do present with severe respiratory distress. But I think generally speaking, it all kind of goes into the category of respiratory symptoms and then possible fever. But, an absence of these symptoms or an absence of some of these clinical findings, if there is a high enough clinical suspicion in another way, I think it's still wise to take it into heavy consideration.
I have a quick question about that. So sometimes we think of the severity of symptoms along a spectrum, right, from mild to severe, but within, say, mild or within severe, is there still heterogeneity? So in some cases, might you see no fever and then more, I don't know, arthralgias, and then in other cases, you might see more fever and then more pneumonia like symptoms. So even among mild cases or even among severe cases within those respective categories, is there a heterogeneity of symptoms so that we can't say yes or no based on the symptoms alone, whether or not somebody, or we can't say with necessarily with much confidence yes or no whether a person might have a disease given the constellation of symptoms that they have?
I think the heterogeneity probably exists more in the mild cases. As people become more severely ill with COVID-19, I think the data does seem to suggest that they do kind of become more homogeneous. So in those situations, the people who are critically ill and on ventilators, I think do clinically appear more
Got it.
consistent.
Yeah,
Interesting.
and I mean, we all know, like, patients are not going to follow the textbook. Like, the textbook presentation for COVID right now that we're being taught is fever, cough, shortness of breath, or some other respiratory ailment. And what we're finding is that, sure, these symptoms might eventually develop during the course of disease, but at that point in time when you're seeing the patient either in clinic or in the ER or even, out in the community or so on, they may not have fever or they may not have cough yet. And so I think it's challenging to hang your hat on, a spectrum of syndrome of symptoms and say, oh, this definitely is COVID or this definitely isn't. We just, and what Tom was saying, we dramatically are underdiagnosing COVID, especially mild COVID or even asymptomatic COVID. We don't understand the full spectrum of disease and the full spectrum of symptoms. And even this past week, I saw some reports of patients now presenting strictly with GI symptoms. Like, they're coming in with diarrhea or nausea. They're not even coming in with fevers or respiratory symptoms. So there is, we don't, we can, we know that most people will eventually have a fever and most people will develop probably some sort of respiratory syndrome, but I would not say that, oh, because you have a runny nose or you have sinus congestion, that I can feel reassured that this isn't a presentation of COVID. And I think as we, go through the next few months and we get more experience and are able to test more patients, um, we'll maybe be able to understand the clinical syndrome and the clinical presentation a little bit better.
Yeah, I think one very accessible example and easy to understand one would be that patients with heart attacks don't always present with chest pain. So somebody that comes in with an acute MI, not all of them come in having chest pain. Some of them actually have abdominal pain. Some of them just feel nauseous. Some just feel sweaty. So it's widely variable for all sorts of diseases. But that's kind of an easy to understand example there.
Right, that's a good analogy. That puts it together. Anything on testing for COVIDs for SARS-CoV-2? Have your institutions made any? Well, I shouldn't ask about the institutions, but have you seen any policies of what criteria is met for testing? What if patients want to know, what do I need to have such that I should go out to seek to get tested for COVID? What needs to be there in order for that to happen?
So as of now, I think most institutions are starting to head more towards a more broad criteria. And that is, fever plus signs or symptoms of lower respiratory illness place you in the suspicious category. That being said, not everyone in that category is going to get tested because of lack of resources. So usually what happens is, there has to be some sort of like an additional reason for testing. For example, if you are symptomatic to the extent where you need hospitalization, then those people get tested. If you are potentially like a healthcare worker that needs to know if you're positive or not in order to return to work, then yes, you could get tested. And then there are other sort of graded criteria as well. So this is something that again is not uniform across the country. It varies from institution to institution, but I think generally speaking, for people who come to the hospital, what we're starting to do is go more broad, and that just means that whoever gets admitted to the inpatient service with a fever or signs or symptoms of lower respiratory illness generally gets put under investigation for COVID-19.
Okay. And while
Yeah,
yeah, go ahead, Mary. Sorry.
we are, I work at a few institutions, and every institution seems to be kind of trying to do the best that they can with their individual resources. And I think that if we were like South Korea or um, a country that's really ramped up testing on a more rapid basis than what we have currently done. I think if tests were widely available and we had fast turnaround times and it was free for everyone, that yeah, we should be testing more patients. But because um, there's such limited access to tests, even to this day. Like the first case of COVID in the US was 3 months ago, and even now we're still having a difficult time testing broadly. And so we have to decide, well, whose clinical management and impact will will we be able to actually impact with a positive test? And so those are the patients who get admitted to the hospital. They get admitted, they get put on under isolation, and then the question remains, how long do they need to be on isolation for? And so if we can test these patients and we can say definitively they don't have COVID or they do have COVID, then we can make, you know, clinical decisions based off of that, and also help protect our PPE resource. So, and then the healthcare workers who get exposures and then get sick, those are also the um, individuals that tend to not have as hard of a time getting access to tests. But it's definitely still a problem having, the people who really need to be tested, getting access to tests, and also having these tests come back in like a clinical meaningful timeline. Like sometimes it can take up to a week before you get the results, and a lot happens within that week with a patient. So I do hope that as a my state and also as a country, that we will quickly be able to ramp up testing over the next few weeks. And but right now, like if you are someone who maybe has a little bit of a cough, but you're not that sick and you're doing okay, then the recommendation is for you to probably just stay home and isolate and, take care of yourself and not go out in the public or be around other people. But the likelihood, at least where I'm at, of you, someone who's doing fine in the community, of getting a test for COVID right now is very, very, very low. And I don't know if that's how it is um, up where you are, Tom, but unless if you're sick coming into the hospital or one of these frontline workers needing to get back to work, we really are not able to scale up testing to the general public at this point.
Yeah.
Yeah, that is what I'm seeing. And I think, just to clarify, when I said earlier, fever or signs of lower respiratory illness are enough to kind of create the criteria for when we pull the trigger to test. That's strictly for an inpatient setting. It's very different from an outpatient setting. So if you are an outpatient and you have fever and cough or, lower respiratory symptoms, most of them are not able to get tested because we're trying to reserve most of it for the inpatient side, for the hospitals. So there are algorithms and protocols that exist for the outpatient setting, and I think they're trying to target the people that are higher risk in the outpatient setting, meaning the elderly patients, patients with underlying lung disease, lung comorbidities, diabetes, etc. But the majority of the testing, as far as what I'm seeing in our region, is mostly still being done inpatient.
Gotcha. And we mentioned, so we spoke a little bit about, to Mary's point, she spoke about the turnover time of the tests themselves. And some tests come back quicker than others, but we still have tests, obviously, that are taking a week or so to come back. In the meantime, there are other labs that do come back. And one of the things we've heard about is you get a CBC and you see the leukopenia, lymphopenia. Are there any labs like that in the meantime that come back before the test turns around that would change your clinical suspicion one way or another?
So I think, as far as clinical suspicion, I think you should have a high clinical suspicion based on symptom presentation, clinical presentation alone. I think, there's no way. So for example, a patient that gets admitted, if you are suspicious of COVID-19 up front, then I think you need to designate that person as a person under investigation right away, a PUI. Then they'll undergo, the rule out process where they send out the samples, and then you get COVID-19 tested and see if it comes back negative or positive. Sometimes you might even end up discharging those patients before the test comes back, and that's fine too. As far as the other lab markers that you're talking about, and those include things that were studied in China, those are things like a D-dimer, procalcitonin, LDH, and lymphopenia or leukopenia. Those are things that were suggestive of being higher predictors of mortality. In other words, just when they compared survivors and non-survivors, or when they compared patients in the ICU with high levels versus low levels, high levels correlated with poor survival. And so that's kind of how that data becomes more relevant. Less so in a situation where you can say if they have a low D-dimer or a normal white count or a low LDH, they probably don't have COVID-19. Probably can't use that data in that way.
Gotcha. Oh, and we just going on to treatment a little bit. So we obviously don't have a proven treatment now for COVID, but we have certain candidates, as everyone knows, that are starting to pop up. We've seen chloroquine, hydroxychloroquine, plus azithromycin, remdesivir. What do you guys think about these potential candidates and where the evidence stands with them?
Okay, I will talk about the chloroquine and hydroxychloroquine, which I think that right now the country and maybe some parts of the scientific community are, we're in this state of panic and we're in this state of wanting to find something that works as quickly as possible. And in the process of doing that, I think that we've kind of leapt to some conclusions regarding some of these therapies that are out there, that in a more rational and unpanicked situation, we would not have come to these conclusions so quickly. So, starting with kind of the antiviral group that we are currently testing and also debating. So, chloroquine and hydroxychloroquine, they're essentially very similar. Chloroquine is a little bit older and it's a little bit more toxic. But both of these drugs have been around forever, and they've been used to treat malaria kind of in the past, not so much anymore. But hydroxychloroquine we actually use pretty frequently in a whole bunch of different types of autoimmune conditions like lupus, for example. And we know that it's effective for these autoimmune conditions. So, the way that I'm not entirely sure what the mechanism of action for these drugs are in terms of their activity against COVID, but I think it has to do with inhibiting viral entry into cells and some other proposed mechanisms that I don't think have really been proven. So, we know based on some in vitro data that it seems like hydroxychloroquine might have more potent activity against COVID compared to chloroquine, but that's, in vitro. And we commonly in the medical community find that things that work, that pan out in the lab, or things that make sense physiologically, don't actually translate well when you test them in a, clinical study. So, these are all hypotheses that have been generated based on what we've observed in the lab and maybe some few cases out in China. But I don't think that we have any definitive answer right now that chloroquine or hydroxychloroquine really makes that much of an impact on clinical outcomes that really matter. So, like mortality or disability, and that's something that we're not going to have the answer to for quite some time, even though there are several trials ongoing trying to answer that question. So one thing that is happening right now, which I do think is interesting, is there's I think a study that they're enrolling out of Minnesota where they're trying to find patients who've been exposed recently to someone with COVID but don't have symptoms yet, and to see if there's a role of using hydroxychloroquine for post-exposure prophylaxis. And I know that they are trying to recruit healthcare workers predominantly, but also like household contacts. So if you have someone in your household who gets diagnosed with COVID and you find out and it's been less than, I think, 72 hours is their cutoff, you can potentially reach out to this group in University of Minnesota and see if you qualify to enroll in their post-exposure hydroxychloroquine trial, which I think is really interesting. And hopefully we'll get some data from that in the next few months. So that's kind of my opinion about hydroxychloroquine. And chloroquine is it's made its way into some guidelines. I think chloroquine's made its way into the Chinese national treatment guidelines for COVID, but is it evidence-based? I think not at this point, and it's more kind of probably an emotional decision, that they had to make. And what we've seen here at the U.S. epicenters, I think at UW, or University of Washington, out of Seattle, they publish their treatment protocols publicly available online for anyone who's interested and to see what they're doing. And they are recommending using hydroxychloroquine for, their moderate to severe cases. But is that, once again, actually evidence-based? Certainly not at this point. And I know that Tom had some thoughts on the new study that came out looking at hydroxychloroquine and azithromycin, and we discussed this earlier, so I'll let
Yes, I am very
take
interested in that
over.
because I've heard about this study, so I'd love to hear what you guys think about that. Tom.
I think the first thing that you have to understand about the study is that, and it self-identifies as this, but it's an open label, non-randomized study. And open label means that it's a non-blinded, meaning that the test subjects or the patients in this case know exactly what they're getting. And the downside of that is that you can't control for placebo effect. And then the non-randomized aspect is that you don't know if your study results are you don't know if you are getting the results that you want to get simply because of the way that you've designed your study. So there are a lot of fallacies. There are a lot of scientific and study design fallacies in the way that it was set up. And I'm not criticizing them because I think, this was done in the context of a crisis, right? They did what they could. And I think a lot of things are happening in that manner right now. And it's simply out of a necessity to see, just getting something out there and getting any sort of anecdotal even experience out there. Because again, as Mary mentioned, it's going to be a while before we have proper randomized control trials for these drug trials. As of right now, what we're operating off of is mostly anecdotal. And I would say that, this study, which was open label, non-randomized, is probably not much better than anecdotal.
Gotcha.
Yeah, I completely agree with that. And if you look at, I think someone on Twitter actually broke this down really well, but if you look at how they, the actual outcomes that they were looking at, I think they had, let me see if I have the numbers. They looked at 36 confirmed cases over the course of a week. And then they basically swabbed these patients' nasal passage, on several days including on day 6, and they wanted to see if either placebo versus hydroxychloroquine by itself versus in combination with azithromycin impacted the viral load on the swabs. And they found that in the quote placebo group, only 12.5% went down to 0, like undetectable virus in this nasal swab at day 6. But then I think in the hydroxychloroquine group, it was like somewhere between 50% for the mono versus 70% if you combine the mono plus the azithromycin group. And so based off of that alone, that's where all of this excitement about using this combination regimen for, kind of desperately so for treating COVID. This is the one clinical study that we have, and it's a small study, and there are definitely issues with the study design. And I think we're just like, in any other setting, we would never be making national guidelines or making treatment, decisions based off of a study like this. And it's great for hypothesis generating. Like, we need stuff like this to come out and say, hey, look at this signal that we're picking up. But I don't think we should be, acting upon this tiny signal so broadly that we're seeing. Like, in some states are having a difficult time now finding hydroxychloroquine for their autoimmune patients, like these patients who are on hydroxychloroquine for an FDA approved medical problem. They're having a hard time accessing this drug because people are, using it, I think, irresponsibly right now. And same thing with azithromycin. Azithromycin is a very common antibiotic that's been around for a long, long time, but it's critical in treating pneumonia, pneumonia from bacteria. And it's a medication that isn't without side effects too. That's something that we forget. Azithromycin and chloroquine both have cardiac toxicity. And hydroxychloroquine does too, to a certain extent. And hydroxychloroquine can cause irreversible blindness, generally with a more prolonged course. But it's not; these aren't completely benign interventions either, for either the person getting the drug or the people who actually need the drug but are having problems getting access now. So, and then one thing I wanted to point out in that the combination group, the hydroxychloroquine plus azithromycin group that they looked at, um, they I think excluded 6 patients who were initially enrolled from the final analysis because they weren't able to get like a day 6 swab. And then if you look specifically at what happened to some of these patients that were eliminated from the final analysis, 3 of them went to the ICU and one of them actually died. And at the time of death, that patient had a negative swab. So what does a negative swab even really mean? Like, can we correlate having a negative swab to, okay, you're going to be fine? So there's so many unanswered questions. I think it's an interesting signal that we need to really pursue, but to roll it out, the way that it has been from a federal level, I think is honestly, it's insanity. It's my opinion.
Gotcha. Yeah.
Yeah, I think Mary mentioned the desperation, kind of that's seemingly sort of driving force behind all of this. And I think, we are in kind of desperate times, and I think that's I agree that that's the reason that this is taking place. Under normal circumstances, this is the type of study that all of us would look at and say, oh, definitely need more information before I take any of this seriously. I think right now what people are probably forced to do, or forced to start reckoning with, is the idea of, if a patient is on death's doorstep, or if things are really not going well, can they sort of can they rationalize the risk versus the benefit of giving one of these medications that does not have solid evidence behind it, right? In a situation where it's like we have nothing else, I think clinicians are being put into these situations where they do have to make that kind of a decision. If the risk is low enough and there is possibility that I could, help prevent this death, then I think that's probably what's going through people's minds as they are making these decisions to give these medications on the front lines. I don't think it's because they actually believe that the evidence is strong. I think all of us are aware that the evidence is, again, anecdotal at best.
I would like to add something here. So Mary was talking about the fact that chloroquine hasn't had its efficacy established. We don't know that it actually is beneficial in a rigorous way, and also that it might have toxicity. So the worst case scenario here is that we could do, and this is within the range of possibilities of if we do a randomized controlled trial with a substantial number of patients in a way that is rigorous, the way that drugs are normally tested, and when we do it and when we get those results. Within the range of those possibilities, given the information we have right now, is that hydroxychloroquine could be more harmful than beneficial. So it could actually cause more problems than it could cause a benefit. So that's why, as Tom is saying, many doctors are sometimes using it only as something of a last ditch or a last possible measure that might help in situations that are desperate. And a lot of times people listen to these discussions about the potential criticisms of these trials, which are incredibly important, and I engage with them all the time, as people who know us on this podcast know. One of the things, though, is many people who have less of an understanding about how clinical trials are conducted and designed and evaluated, some of these criticisms may not resonate as much with such people. I know that many of our listeners are quite well educated about these things, but some people may have still quite a few questions about how to think about these trials. And so what I'll say to those people is, yes, in this particular study, which is essentially an anecdote because it's not well controlled, it's essentially an anecdote. We saw anecdotal evidence of efficacy of hydroxychloroquine. On the other hand, we've also seen, if you go on Twitter or many social media channels, we've seen doctors, we've seen patients, but especially we've seen doctors who have been put on hydroxychloroquine who were in a bad situation and things got worse. So just because we have some evidence doesn't necessarily mean that it's going to be a really wonderful treatment for COVID-19. It could be, and I think everybody here hopes that it will be, and that would be, as to quote one prominent public figure, that would be a medical miracle. But we don't have that information yet.
Gotcha.
Yeah, I completely agree with that. And the course that we're seeing in this trial, I think if you add up the number of tablets for one course of hydroxychloroquine, for this study, it was 30 tablets for each person, right? And then if you look at some of the other protocols out there, they're recommending like try it for 5 days or try it for 10 days, and it's a medication that's dosed twice a day. And so it adds up. And if we do this on a massive scale, we're going to run out of hydroxychloroquine and chloroquine very quickly. And then what happens, at what benefit? And then what happens to the patients who actually need these drugs for their lupus or for their other autoimmune problems? So I think that it's a complicated issue, and I completely agree with Tom that it's really hard when you're in the ICU with that patient who's not doing well and you want to do everything in your power to save that person. But if there's anything that offers a glimmer of hope, then some people tend to, reach for it. But we have to understand not just, what is the possible impact for my patient, what is the risk benefit ratio for my patient that I'm treating, but what is the risk benefit ratio for society as a whole right now? And I don't think, I think that there's a lot of doctors on social media who are talking about that and talking about their experiences now with having problems, filling hydroxychloroquine scripts, or pharmacists filling hydroxychloroquine scripts for patients coming in who actually need these drugs. And I think that's going to be an issue going forward. I saw some reports of some pharmaceutical companies, pledging, a million tablets of hydroxychloroquine to donate here and there. But this COVID's going to be around, guys. It's going to be around for months. In the United States, it's going to be around for even longer throughout the world. We don't know if it's going to be one of these seasonal viruses. Where I currently live, it's about 80 to 90 degrees outside, so it makes me wonder a little bit about the seasonality. So, we need to be judicious in our resources going forward with our PPE, with our masks, with our drug supply, and recognizing that the US supply chain for medical supplies and pharmaceuticals is not something that it's not secure right now. So I think we need to just be cautious about what we're doing, even though I do understand, you want to do the best for the patient that you have in front of you, but we have to think at a systems level too.
Right. We're gonna
Absolutely.
we're gonna shift gears a bit here. We're gonna go into the Q&A session. We do have a lot of questions. Oh, unless you have
Yeah.
something else you want to, Kev.
Well, it's been about an hour. Do we want to keep going with the Q&A, or do you guys have something we want to respect your time, so
Oh, absolutely. Yeah, sure.
you guys are doctors dealing with the pandemic, so it's what do you guys think?
I'm fine to keep going for a little bit. That's okay.
Cool.
Same here.
All right, then we'll get Jennifer on. Jen, you want to take the questions?
Yeah, we only have about 9 questions. Some of these are merged together, so you won't hear your names, everybody. First question. What is this business about NSAIDs not being a good choice? Is it usually relative?
Jen, your mic's just a little bit muffled.
Can you hear me now?
No, it's still muffled, Jen.
Try again.
Okay, let me go to a different part of the house.
That's better. That's better.
That sounds good right there.
Okay, awesome.
Yeah.
First question. What is this business about NSAIDs not being a good choice? Is it the usual relative contraindication with asthma, where it can exacerbate asthma by possibly increasing leukotriene pathway?
So
I don't.
you wanted to
I can try to take a stab at that. I don't completely understand
go ahead.
the mechanism that we're concerned about, but I've talked to a lot of rheumatologists about this who are familiar with the use of NSAIDs in treating all of their, arthritis patients, and none of them seem to be particularly convinced that there's enough data to make a recommendation on the use of NSAIDs like ibuprofen or Advil um, in the COVID era. So, I think since we don't know, and there might be some concern from a purely speculative background that NSAIDs could exacerbate COVID presentations or severity of disease, that if you want to avoid using ibuprofen and use, acetaminophen or Tylenol or something else, or not use anything for fever management, I think that's a low risk intervention to make on an individual level. But I don't think we have really any data suggesting that NSAIDs are harmful for COVID at this point. But if you want to be careful, I don't think it's a big deal if you decide for yourself, hey, I'm going to avoid using ibuprofen if I get sick. I don't think that's unreasonable.
Jen, I think your mic cut out again.
my gosh.
Okay, there we go.
Okay, I have to stand really awkwardly. Okay, do we have an approximation on the distribution of cases that require hospitalization and ICU? And why is it that we have such a significant difference in hospital admissions by age from country to country? For example, a new paper stated that 40% of patients admitted for COVID-19 were between the age of 20 to 44.
I think the first one is probably kind of easier. The first part of that question is probably easier to tackle. So the most recent MMWR that was published by the CDC, which details um, about 4,000, I think about 4,500 or so, or 4,200 or so patients that have been reported as COVID positive so far in the US. Out of those, they have full data on about 2,000 or so. And out of that 2,000, as far as how many of them have been going to ICU, it looks like the findings are somewhere between 5 to 12%. So that's that piece. And then, and I'm sorry, could you repeat the second part of the question again?
Jen? Oh, is she losing?
Oh,
Service.
oh,
Oh, here we go. Yeah, I can hear you.
So third question, are children safe from the illness, and what seems to offer them more protection?
Jen,
The second question, Jen. Second
yeah,
question.
reread this.
Oh, I'm so sorry, I couldn't hear. Okay, the entire question?
Just the second part of it. Let's see.
And why is it that we see such a significant difference in hospital admissions by age from country to country? For example, a new paper stated that 40% of patients admitted for COVID-19 were between the age of 20 to 44.
Yeah, I think that's probably a more that's probably a more challenging question in that, you know, comparisons between countries. So the big issue is that, you know, while we take a lot of the data from China and Italy, the thing we have to remember is that we can't necessarily generalize all that data to our own country. Whatever happens in China is not going to be an exact replica of how patients in the US respond. Or, you know, same with Italy. You know, these are people who have different genetics, who have different percentages of various comorbidities, who also have different diets even and different exposures. And so the actual proportion of people who are in different age groups admitted to the hospitals might vary substantially just based on that alone. And then I think the other piece of this is that, you know, this probably also has to do with testing. If we were at 100% test capacity, then our numbers might actually mimic other countries a little bit more closely. But the truth of the matter is that we're not. So our numbers are probably just going to look different for a while. I don't know if Mary has any other thoughts on that.
Yeah, no, I agree. I think I don't know what study that was specifically looking at was it 20 to 40-year-olds who were admitted to the hospital. That might have actually been the CDC NMWR report that you were just talking about, Tom. But in the United States, it seems like at least this early cohort of patients that we've looked at over the course, I think since between January and mid-March, it seems like 20% of the patients who were admitted to the hospital or something like that ended up being in a younger group. And by younger, I mean relatively so kind of within the 20 to 45 age range versus the older groups. And that probably is mostly just driven by the fact that we are grossly under testing and unable to even correctly diagnose COVID cases in patients who were admitted to the hospital. I mean, testing was so limited in the month of February and January that even if you had a patient in the hospital with unexplained pneumonia, if they didn't have that strict travel criteria of having been to this part of China or having been to, this other part of the country or this other part of the world. They no matter how sick they weren't eligible for a test. Like this was even back in I think mid to late February when I was um, on service at one of the institutions around here. So it it's hard to speculate why there's that discrepancy, but I think as we move forward, we're going to start seeing. I mean, there even in the I think in the past week or so, I saw several reports of young people being admitted with severe COVID and patients who didn't have any significant comorbidities. So there's so much that we still have to learn. I don't think that um, I can really explain away why there's a difference among countries at this point. And then obviously, like access to healthcare is going to determine like how adequate your access to healthcare and resources are. That'll also have an impact on your outcomes on a population level.
I can take a stab at this. So I just looked up while you guys were talking. I just looked up one of the CDC's reports, and one of these reports is called Severe Outcomes. It was published on the 18th this month, and it's called Severe Outcomes Among Patients with Coronavirus Disease, 2019, United States, February 12th to March 16th. And they have a bunch of quite interesting tables. It's on the CDC website. They have a bunch of quite interesting tables. One of them is, I think, they only have one table and they have two other figures. In that one table, they show that of people who are aged 20 to 44 years old who have gotten a diagnosis, between 14 and 21% are hospitalized. And so, to be clear, it's not that 40%. I mean, I'm not implying that. The question didn't ask or suggest that 40% of people who are this age are admitted. It suggested that 40% of all patients are of this age that are admitted. So, but that's still pretty high. It's about a 1 in 5, up to a 1 in 5 chance. That said, the reason that 40% figure might be the case is, I think this is a plausible factor. It's a likely factor that explains for at least part of that, is that the age distribution of America compared to Italy is substantially different. So there's a lot more older people in Italy, whereas our population pyramid or age pyramid has a higher number of people who are much younger. So just by virtue of that, just by virtue of having a lot more younger people, we're going to have a higher percentage of total number of hospitalizations among people who are younger, just because there's more younger people. So that would be my stab at that question.
Yeah, I think, still probably the number one question to answer about that question is that a real signal? As Mary and I think have been discussing. But then I think the other thought that I'm having now is that if that signal is indeed real, is social distancing among different age groups playing a factor? So are younger people doing a poorer job of social distancing and therefore contracting more of the illness right now? I think that is also a plausible explanation if that signal is real.
Okay, so finally, the next question. Are children safe from the illness, and what seems to offer them more protection?
I think that's an interesting question. And what we're learning right now is that kids who get COVID tend to have a more mild clinical course, and they're not the ones who are getting super sick and needing to be admitted to the hospital and intubated on ventilators and so on. And we're talking about kids who are otherwise generally very healthy, not kids with, significant comorbidities like type 1 diabetes or leukemia. I think those kids are definitely still at high risk for severe disease and poor outcomes. But for your average healthy, toddler or preteen, I think it's been remarkable that we haven't seen, that many severe cases, even in China and in Italy, throughout the world, and even here in the US. And what protects them is something that we don't know. We don't know what the answer is to that second half of the question. We don't know what it is about kids that seems to protect them against developing severe disease, but that's something that's being looked into. And I don't have any guesses as to why they seem to be more protected. But it's a fortunate thing that we've um, encountered so far with COVID.
Okay. Oh, go
And
ahead.
I would like to add to that because I'm still on this. It's remarkable just to look at the age difference. So you look at 20 to 44, as I was mentioning, assuming that these numbers um, are representative of the reality on the ground, as Tom mentioned. But if they are, among the 20 to 44-year-olds, the rate of hospitalization was, as I said, 14 to 21%. ICU admission was 2 to 4%. But if you look at the 0 to 19, and there's 123 cases there, 0 to 19 years old, instead of 14 to 21%, you have 1 to 2%. And you have ICU admissions of actually 0, and not a single case among the 123-year-old that are of this age. Not a single case had an ICU admission or a fatality. So it's like a tenfold decrease if these figures are representative of sort of the severity. Although but it's it's a massive difference between 2% all the way up to 21%. It's like a tenfold difference in percentage of cases. So I find that really.
Yeah, and you know, I think that we'll find that there's a lot of kids out there who probably do have COVID and maybe are not especially symptomatic, or they just have, the usual kid sniffles that we're not diagnosing. And so the mortality and the severity of disease in children is probably even much, much lower than what we're able to capture through testing. So I'm really glad that it seems like at least children are relatively spared from COVID. And that's something that I know people are looking into, trying to understand why, and maybe providing a clue into future targets for therapeutics.
Okay, next question. Your take on people promoting supplements like zinc for preventing or even curing COVID?
Yeah,
Um,
think
I don't think
I think that probably does.
go ahead.
Yeah, I think that probably still falls into our similar stance on, trying to make sure that we have evidence and good solid evidence for doing things. But that being said, again, if there's a low risk intervention that seems reasonable to do, and if you know that the potential for harm is going to be very low, then there's not a whole lot of downside in taking like a zinc supplement, I don't think. Same idea with taking Tylenol instead of ibuprofen for a fever.
And I hope the people who are promoting supplements are also promoting the things that we know are effective, which includes the physical distancing, hand washing, stay home. Like, I hope that those interventions are also being promoted in addition to uh, zinc and whatever else may be out there.
Yeah, I think there's like a public. I feel like sometimes there is a public misconception that physicians are upset when unproven supplements are recommended by other parties, and I think it's not that piece that really upsets us. It's when those are recommended as opposed to normal medical treatment in place of medical treatment. So I think, again, zinc supplements, if you don't have an allergy to zinc, probably fine. Just don't expect it to take the place of normal medical recommendations.
Okay, next question. Are draconian lockdowns a la China the only way to get through this?
So if we were in January right now, and you can see actually, Singapore, I think, was it Singapore? No, sorry, South Korea and the United States had their first COVID case, I think, on the same day. So we had it arrive in our country, and South Korea had it arrive there on the exact same day. And you can see a dramatic difference in our national response. And you can also see the consequences of those dramatic differences. So I think if we were in January, there were, you know, lots of things that we probably could and should have done differently. Um, but now we're at a point where I would not be surprised going forward if we were to pursue one of these draconian lockdowns, either on a state, at a state level or a city level or even nationwide. And I don't necessarily think that's a bad idea, given how, especially what we're seeing right now in New York and what's um, happening there in Washington State. The rest of the country will be exactly where they are shortly, and unless if we take dramatic um, action at this point. And what makes it challenging to do what South Korea has done is that they were testing what, like 10,000 people a day or something crazy, and we were lucky to test like one patient a day. So I think we might be the only option we might have are these draconian methods, which is straight up lockdown, quarantine, nobody leave their house unless if you absolutely need to for, a medical reason or because you need supplies or something. But we have so few tools in our toolbox right now to fight this pandemic, especially given where we currently are in the United States. That's my take.
Yeah, I think the short answer is that no, those measures are not the only measures. But as time goes on, the measures that are going to be useful become more and more limited until, draconian lockdowns are the only thing that you're left with.
Next question.
Yep.
Oh, okay. Are low or high ACE2 expressions in XYZ tissue associated with worse disease? And does it acutely lower levels of T lymphocytes?
Hmm. I have no idea.
Yeah, I'm not
I
sure about that one either.
I'm gonna have to defer.
Mary and I have discussed, we did talk about kind of, we have talked about sort of this, within the scientific community, there's this idea about possibility for ACE inhibitors increasing chances of harm in people infected with COVID-19. And I think it's another one of those kind of unproven theories that right now is kind of picking up steam and gaining some attention. But as of right now, we don't know what really to do with the idea. And I think there's very limited data that we also don't know what to do with. I don't think that there are any major or actual evidence-based recommendations that we can make about ACE inhibitors at this moment.
All right. And next question, do we have any headway on discovering the length of exposure immunity? And how would they even go about finding this out?
Could you reread the question? You were a bit more.
Not again. Okay. Do we have any headway on discovering the length of exposure immunity? And how do we even go about finding this out?
I think she's asking how long do people stay immune when they're infected? If we can make any extrapolations or anything based on, can we do it based on other coronaviruses? How long do people stay immune when they're infected with the coronavirus? Can they get reinfected and then become vulnerable again at a certain time? Does their immunity wane? I think that was the nature of the question.
Gotcha. I think the short answer is probably after exposure, even after clearing it, you probably are not immune very long. And I think, I myself don't personally understand all of the science behind it, but the way I think about it is that generally speaking, coronaviruses in the past have just been a common cause of the cold, and you can get a cold like even a week or two after you get a cold. Sometimes by a different virus or sometimes by a virus in the same family, but the immunity from getting infected the first time, I think, is very sort of difficult to continue, and I think it's also part of the reason that a vaccine in this situation has also been very difficult.
Okay, just a couple more questions. So, second last one. Could it be that social distancing entails another largely unaccounted for benefit? That being reduced viral load in those that do become infected.
I'm sorry, was the question that social distancing decreases the viral load in those already affected?
Yeah.
Oh, I'm not sure how it would do that.
Let's move on to the next question.
Yeah.
No problem. Okay, how many undetected cases do you think there are? Obviously, there are many undetected cases, but what is a realistic range of possibilities?
That's an excellent question.
Yeah, it's a good question. If you find someone who knows that answer, could you have them call us?
Well, this is something we were talking about actually with that ties into the case fatality rates of the CFRs that Kevin and I were actually talking about. So we hear this idea that the CFRs are over exaggerated or overestimated, the mortality rates are overestimated, and we ask why, and they say, well, because there's a lot of people, not just asymptomatic, but people who aren't tested. And of the untested population, if they were tested, you would increase the cases and the deaths would stay the same. And so we are overestimating the case fatality rate. And then my retort to this has always been the speculation for the bias, the direction of the bias for the untested can just as easily, there are certain biases that go toward that, but there are certain biases that go the other way. For example, of the untested population, certain biases go toward that we are underestimating, not overestimating. For example, you have people who die before they can get tested. You have people who go to an emergency room and they die because they just don't have a shortage of tests, and so the cause of death just gets chalked up to ARDS, to pneumonia, even if there would be a clinical suspicion of COVID-19. And so my take right now is I don't see why of the untested people, of the people who are untested, I don't see why there would be any bias that we would conclude one wins out over the other. So of the untested bias, I don't see why we could conclude that we would be overestimating any more than we're underestimating.
Yeah, so to ask a question on that, because I like Avi's idea, and I was actually promoting it at the beginning, and then I just started because I'm always asking questions about everything. So one question I have is, do you guys see cases where you think it could be COVID-19, but they die before they get tested? Is that happening a lot? Or are there cases that people are aware of that might have happened?
So from the inpatient side, generally speaking, no, we don't really see cases that die too quickly, because in the event of any sort of suspicion for COVID-19, the testing happens usually immediately in the emergency room before they're even admitted. So the sample gets sent out. Now, that being said, the patient could, in theory, die before the sample comes back with a result.
Or they could,
but we would probably always know.
Or they could be tested get a false negative, which is not incredibly uncommon, right?
Yeah, exactly.
Then it would just be the people who are dying en route to the hospital, and they presumably wouldn't get tested for COVID. We're not testing dead people who arrive before they get to the who die en route to the emergency room, or before they can get emergency services. I presume.
Or people who just have COVID-19 who get a false
Correct.
negative and then they die. Yeah, so that could be true.
Yeah, and COVID-19 is not something that is a fast killer. Generally speaking, infectious diseases that kill things fast would not result in a global pandemic of this proportion. For example, Ebola is something that kills very fast, and it kills people too quickly to spread it very far. I will say, with regards to the mortality rate, though, I'll say this because I think this piece is important. The mortality rate, whether it's 2% or 3% or even higher, I think is something that we are focusing maybe a little bit too much on. I think as nationwide, the numbers definitely are higher than the mortality rate for flu. But the real thing that is concerning is how fast and how much comes in all at once. So, for example, the mortality rate of this is much lower than the mortality rate of car accidents in a year. More people are probably going to die of a motor vehicle collision in this year than will die of COVID-19. But if you took all of the people who are going to die of motor vehicle accidents in a single year and brought them all to the hospital in a period of a few months, then you would have a real problem. And that's really what the problem of COVID-19 is.
Absolutely. That's such a beautiful way of putting it. Okay, does anybody else? I guess we are at the end of our questions. That was a wonderful session between. That was a wonderful session with you two. Does anybody else have any other comments before we wrap this up? Okay. Well, fantastic. That was. I felt like that was a pretty amazing discussion that we had there, and I want to thank the two of you for the time that you spent looking at the questions that we sent you and thinking about them, and of course for doing the service that you have done and will be doing in the coming months to help people who are becoming infected with this terrible disease.
Yeah, just reiterate, thank you so much for your time. Thanks for doing this. Thanks for putting this together, and hopefully it gives the public better information than what's currently been going on.
Yeah, thank you guys for having us on.
Thank you for having us.
Can I end with one plea? And it's that if there's anyone out there who has, for some reason, no judgment, a hoard of masks of any sort, like surgical masks or N95 respirators, or even gloves we might be running into problems with in the future. If you have any to spare, focus on the physical distancing aspect of all of this. If you have any masks to spare, please donate them to your local hospital or local clinic or any physicians you may know. I think there's a website that's trying to match like providers with people who have a surplus of masks for some reason. But if you already have like a giant stash somewhere, please consider donating those masks. And then the other thing that we are in shortage of right now, and this might impact you or someone you know, is we are in shortage of blood products. So if you're capable of and willing to donate blood, that's something that would be very, very helpful, that basically anyone can really do. So those are the two pleas that I will leave with. And thank you guys so much for having us. It was a lot of fun talking about a serious and scary topic, but I really do appreciate you giving us the opportunity to talk with you guys today.
Thanks, guys.
Thank you so much.
Much appreciated. I would say to anyone else that's listening out there that, it's these are scary and unprecedented times. Nothing is normal about how the pandemic is evolving, and therefore nothing is normal about what our responses have been. But ultimately, what will get us through all of this is all of us working together. So thank you.
Well
Thanks,
said.
Tom.
Thank you. Thanks, Tom. Thanks, Mary.
All right, so that's that. That was awesome. Thanks, guys. That was a really good discussion. So yeah, we're thanks. Bye.
Bye, guys. Thanks for doing this. Thanks for coming.
Bye, everybody.
Bye. Thank you.